Welcome to topic 4, everybody. And this topic is all about inflammation, inflammatory disease, and anti-inflammatories. Now, we will get to inflammatory disease and anti-inflammatories later on. To begin with, though, we're just going to start with a short revision on inflammation and how it plays a part in normal tissue repair. So I want you to think back now to the last time you had some inflammation occurring. Maybe it was because, you banged your finger against the wall or caught it in the door, or you sprained your ankle on the sports field. I'm sure you would have noticed these characteristic signs and symptoms of localized inflammation. That's what we're going to talk about here. When we get to systemic inflammation, we have to add a couple of extra signs and symptoms. So we do have the characteristic signs of redness in the area and heat in the area. We also see swelling or edema. We also have then the symptom of pain occurring too. And in some cases of inflammation, there is loss of function of that region of the body until the inflammatory process has occurred. So what causes these symptoms then? Well, to begin with, the redness and the heat is caused by increased vasodilation and therefore increased local blood flow. So I'll take you over to this diagram here. It's just a little schematic showing you from the aorta, then the branches of the aorta into arteries, which branch further into forming these smaller but more arterioles. And these arterioles literally vasodilate. Okay, so that vascular smooth muscle in the walls of these arterioles relaxes, and that will allow more blood flow then into this capillary bed, which will then open up, okay? And that causes the redness and the heat in that local area, okay? At the same time, these venules that, drain sort of the venous end of the capillary bed, they open up and they become leaky. So there's increased local vascular permeability. So they become leaky, and this allows a protein-rich fluid to enter the interstitium, and we then get an increase in local interstitial fluid, and that leads to that swelling or edema. Now, both the vasodilation and the increased vascular permeability will cause, fluid to compress nerves. And also at the same time, we get these chemical mediators, so these chemicals of inflammation, and there's lots of them that we're going to learn about, activate nociceptors. Okay, so there's pain receptors. And once they're activated, then that electrical signal will be propagated up the pain pathway to the parts of the brain then that are involved in the conscious perception of pain. So just a little bit more on vasodilation and then on vascular permeability. Vasodilation of arterioles occurs due to the action of many different inflammatory molecules, and we've just given you the example here of histamine and also nitric oxide. As a result of the vasodilation, the capillary beds then open up. Then at the venule end of the capillary bed, there is increased permeability. And again, this is in response to particular chemical mediators such as histamine again and bradykinin and other ones, which we'll talk about on the next slide. So you get these leaky vessels, and that allows this protein-rich fluid then to enter the tissue. Now, this is all part of normal tissue repair, and this protein-rich fluid can dilute out noxious agents, let's say, for example, bacteria or bacterial toxins. Now, if you've got fluid leaving the blood vessel, that's going to decrease the amount of fluid inside the blood vessel, right? So relative to the volume of blood left in the blood vessel, there's going to be a greater concentration of red blood cells, platelets, and clotting factors. And so less fluid in the blood vessel will also cause slower blood flow. And this will increase the likelihood of blood clotting. Remember, when things aren't flowing in terms of blood, stagnated blood is more likely to clot. Now, with this vascular permeability, so we're talking about, here in the venules, what you have to imagine is those endothelial cells lining the vessel wall, and they're pretty much stacked kind of against each other, and they're connected by these intercellular junctions, right? So what happens to cause the leaky vessels is that there are formation of endothelial gaps primarily in the venules. So you get little gaps forming between all of the endothelial cells. And this is due to the action of many chemical mediators, but including histamine, bradykinin, and the leukotrienes, which we'll get to later. So let's take the example of histamine as our chemical mediator. Histamine will bind to a specific receptor on the endothelial cell and stimulate the endothelial cell to contract. So literally the contraction of the individual endothelial cells will cause them to pull apart, and you get the formation of this very little, a little gap across which white blood cells can, move through into the damaged area. And so what you're getting is, separation of these intercellular junctions due to the endothelial cell contraction. So what are the benefits then of inflammation, right? Because we all know it hurts, okay? But, the increased local blood flow and the permeability of blood vessels will allow the following to occur. So you get migration of leukocytes from the blood vessels into the damaged area. And these leukocytes, or white blood cells, then, are able to clear up the damaged area. We know that some of them are phagocytic, so they're able to engulf pathogens or debris or dust or things that, have entered from the environment and take them up and remove and destroy them. We also get entry of chemical mediators too, and together the migration of the white blood cells and the entry of chemical mediators will destroy the invading microbe. Okay, now we also have deposition of fibrin to isolate the damaged tissue. Okay, so what I want you to think about here, and you would have learned about it in previous physiology subjects, is that, the liver makes a lot of these blood proteins. One of them is called fibrinogen, right? And fibrinogen is a soluble protein that is circulating, in the bloodstream. During blood coagulation process, that soluble fibrinogen is converted to insoluble fibrin. And that fibrin then is what forms the blood clot. It's like that network of fibers. It's really important in the end sort of response to damage to blood vessels through the blood coagulation process. So it's kind of the same here. You're still getting fibrinogen being converted to fibrin to form that sort of network of fibers and sort of isolate that damaged tissue so that you don't get sort of further spread of infection or things like that. So further invasion of microbes or damaging substances. And just remember as well that, inflammation is not just the result of invading microbes and infection. It occurs as the result of any damage. So you might have a sprain or a strain, which is a form of mechanical damage, which will stimulate inflammation. But so too will things like, insect bites or toxins or lots of other things as well. So the normal sequence of events from the initial damage to a healed wound involves inflammation. So it is essential to wound healing, and it is one of the 4 stages of tissue repair. However, if inflammation doesn't resolve, so if it doesn't, resolve in a particular time frame or in a particular manner, or if it is too severe, then it will cause more damage. And often that damage is worse than the damage created by the initial injury. Now, wound healing itself may involve regeneration or the formation of scar tissue. We'll start here with regeneration. And with regeneration, the damaged tissue is replaced with exactly the same tissue. So it's going to, maintain the same functionality, and it's also going to maintain the original structure. So if you think about, damage to epithelial cells in the epidermis undergoing regeneration, you get replacement of the damaged epithelium with, new epithelial cells completely the same, and that's fine. Sometimes, however, though, a scar forms, and this is due to a damaged tissue being replaced by connective tissue. I'll give you an example of when this might be an issue. So say the heart muscle is damaged, and we know that, muscle tissue, one of its characteristics is the ability to contract. Okay, so if the damaged muscle tissue is replaced by connective tissue, that region of the heart that was damaged can no longer contract. And remember as well that cardiac muscle cells, or myocytes, communicate with each other. So if you throw in some kind of connective tissue there as well, you're going to lose that communication as well. And that results in, scar formation. And whether or not the regeneration or the scar formation occurs depends upon the extent of the damage, so how widespread the damage is, and also the type of tissue that's damaged. For example, tissues containing cells that continue to replicate at high levels in adulthood, like the epidermis, are more likely to regenerate. So if you think back to physiology, we know that there's a supply of stem cells constantly sort of being turned over in the epidermis of the skin. So this tissue is likely to regenerate. However, in contrast, skeletal muscle regenerates poorly, as does nervous tissue. Superficial wounds are more likely to involve regeneration, and this is because epithelial surfaces are constantly replaced. However, the more tissue types that are destroyed, the more difficult repair will be, and the more likely that a scar will be formed. So if you have an injury that sort of extends from the epidermis down into the muscle tissue, you're going to be far more likely to get a scar forming in that case. Now, chronic wounds can result from an ongoing infection of a particular wound, or can result from compromised circulation. So a reduction in blood flow to a wound will mean there'll be decreased delivery of oxygen and chemical mediators to that wound, and also decreased removal of waste products too. Neuropathy, so damage to nervous tissue within the wound, can also lead to a chronic wound. But just keep in mind, that the overall sort of purpose of tissue repair is to allow complete regeneration of the wound and the tissue, and or form a scar to replace the damaged tissue. So we're going to look at the role of endothelial cells and platelets in inflammation and tissue repair, and starting with platelet activation. So activated platelets do release many proteins. Not all of these are characterized yet, so we don't even know some of their functions yet, but they do release over 300 proteins. Now, many of these proteins are thought to stimulate inflammation itself, and some are known potent inflammatory mediators. What do? They can increase vascular permeability, by, altering endothelial cell activity, and therefore the vessels become leaky. These proteins can also stimulate chemotaxis and extravasation of leukocytes. And extravasation just describes the process of how white blood cells get out of blood vessels, due to this increased vascular permeability. They also stimulate chemotaxis. So these proteins will sort of, make these leukocytes more sticky, and they will kind of facilitate their movement towards the damaged area via that chemotaxis. So down that concentration gradient that might form from either damaged tissue or bacterial toxins or something else. Now, I've just got a question for you. If cardiovascular disorders cause blood clotting, what could be a consequence of this? So to answer this question, we need to talk a little bit about thrombus and embolism formation. And we did touch on this last year in physiology, and we will go through it in more detail when we get to the cardiovascular topic. Okay, here we've just got a little blood vessel. What I want you to imagine is that there is this plaque forming here, so atherosclerotic plaque, where there's that lipid deposition in the walls of arteries. Now, sometimes that's obviously going to cause ischemia, so reduction of blood flow through this blood vessel, because you're getting this narrowing of the lumen due to the plaque developing. Sometimes the plaque can crack, and that exposes what we call a thrombogenic surface, where you get platelet activation, platelet plug formation, and the formation of this clot or this thrombus. Now, this clot or thrombus can sort of reduce, blood flow further through that vessel, so cause further sort of tissue hypoxia, but also it can completely block or occlude a vessel, say a coronary artery, to cause a state of anoxia. And if that anoxia then is not ceased, as we've talked about in the previous topic, then we can get tissue necrosis. What else can happen is an embolism can form, right? And an embolus just means a plug. So sometimes part of this clot breaks off and it travels in the bloodstream and eventually then totally blocks a vessel somewhere else. And so I'm sure some of you have heard of pulmonary embolisms, which are these plugs that form in arteries supplying lung tissue. And very often, these pulmonary embolisms, are due to thrombi that are forming in vessels in the lower limb that break off and then travel in the bloodstream to the lungs. So the question was all about inflammation causing blood clotting, but also clotting causing inflammation. So I've just drawn this little diagram here, and we're going to start over here with the process of inflammation. So remember, you get that contraction of endothelial cells, and that creates those little gaps, which allows then for that protein-rich fluid and white blood cells to leave the vessel and enter the damaged area. Remember, if you've got fluid leaving a blood vessel, that's going to slow down blood flow through that vessel. And we know that wherever blood is flowing more slowly, you're going to have increased risk of clotting. So inflammation causes blood clotting. However, clotting can also cause inflammation, as we've mentioned. So here, if you have a damaged vessel, that exposes that collagen, then you're going to get the whole process of platelet activation, platelet aggregation, and the formation of loose platelet plugs. And these platelet plugs then stimulate inflammation. So just to summarize this and to look at phagocytosis, damaged cells release inflammatory chemical mediators, and these compounds stimulate white blood cell infiltration and promote inflammation. Eventually, this leads to the destruction of the pathogen, if that's what's causing the inflammation to begin with, and the fencing off of the damaged tissue from healthy tissue so you don't get that spread of infection. Then we have this big cleanup mechanism. So cell debris is cleaned up in preparation for repair due to phagocytosis by those large white blood cells called the neutrophils in the early stages of inflammation, and then later on by those large tissue phagocytic cells called macrophages. And remember what phagocytosis is. It's that engulfment of particles and destruction of the pathogen or whatever it is. Now, macrophages play an important role in promoting inflammation, but they also play an important role in resolving inflammation and initiating the healing process due to the secretion of growth factors. And it is thought that there is sometimes a breakdown in this switch to healing mode that's linked to acute inflammation progressing to chronic inflammation. So it's thought that the macrophages kind of lose the message to go into healing mode and stay in that pro-inflammatory mode, secreting chemical mediators and phagocytosis sort of phase, rather than going to healing. Now, inflammation, as I keep mentioning, does involve both cellular and chemically mediated changes. When we're thinking about the cellular component, we're talking about the white blood cells, so migration of leukocytes into the inflamed area. Early on in inflammation via the neutrophils, and then followed up later by the macrophages. Lymphocytes also infiltrate into the area to subsequently allow adaptive immunity, and that whole sort of memory component that allows our immune systems to remember an antigen or a pathogen or a toxin once it's seen it previously. Now, to be able to, get into the area, the white blood cells have to attach to blood vessel walls to extravasate. Extra meaning going outside, vasate relating to blood vessels, okay? So I want you to sort of stretch your imagination up here, and I want you to start thinking about white blood cells performing gymnastics, right? If you look at this figure here, you can see the blood flow in this direction. So imagine that that blood flow is flowing fairly rapidly, and we've got our endothelial cells there lining this vessel wall. So what happens is inside that blood, obviously you have these white blood cells, and what they do is they express these adhesive proteins. So these sticky proteins called integrins. So what happens is, they start rolling and attaching and popping off and rolling and attaching and popping off. And as they're sort of doing this rolling gymnastics kind of maneuver, they start to express more and more of these sticky proteins. And eventually, as you can see here, they make a firm stick to the endothelial cell. So the receptor on the white blood cell attaches to the receptor on the endothelial cell. And that then kind of, stimulates that endothelial cell contraction where they move apart. And then here you can see this transmigration of this white blood cell. So it's extravasating there from the blood cell. And then down here you can see it even more clearly where we have this transmigration from the vessel, the extravasation, and then how the hell do the white blood cells know where to go? Well, they do this via a process known as chemotaxis. And chemotaxis involves movement along a chemical gradient. So if you can imagine damaged tissue releasing chemicals, or if you can imagine in this case here, the presence of bacteria, or maybe that bacteria is secreting a toxin, which is a chemical, those chemicals form this gradient and literally drag those white blood cells to the area. It's a little bit like, when you skip breakfast and you're kind of walking along the street and you get this beautiful aroma of toast being made, and you kind of move your head around, you go, oh my God, where's that coming from? And you find the direction that it's coming, and you get dragged to that cafe to have some of that toast. So it's a little bit similar in this way. I'm just going to outline a condition now known as leukocyte adhesion deficiency based on what I've just described on the previous slide. So with this disorder, the leukocytes are unable to adhere to the endothelial cells. Now, if they can't stick to the endothelial cells, they can't efficiently extravasate, so they can't get out of the blood vessel into the underlying tissue. If this is, if this disorder is present, it means that the person is going to be then very susceptible to infections. And an example here is LAD type 1, which is a hereditary congenital defect. So it's inherited, and it's a defect in an attachment molecule called the integrin. So in people that do have this inherited disorder, they don't have this integrin, which allows the leukocytes to adhere to the endothelial cells, and therefore those leukocytes can't get out into damaged underlying tissue, so therefore they're very susceptible to infections. And finally here, just looking at the role of endothelial cells in inflammation too. Now, as we know, the endothelial cells lining vessel walls form this selectively permeable barrier, so allowing some substances to enter the vessel and allowing other substances out. But it's not only just about being a barrier. They also regulate leukocyte extravasation, as I mentioned previously, due to the expression of attachment receptors for those white blood cells. They also release inflammatory mediators, and they also regulate immune cell proliferation by secreting what we know as hematopoietic colony stimulating factors, or CSFs. And you often see this abbreviation CSFs relating to these sort of factors that are present in inflamed tissues that regulate immune cell proliferation. Endothelial cells too are involved in tissue repair, so they produce growth factors that stimulate angiogenesis, so new vessel growth, and also extracellular matrix synthesis in connective tissue, mostly collagen fibers. And endothelial cells themselves are able to migrate and to proliferate to form, barriers in previously sort of damaged blood vessel walls. We'll briefly look at the migration and proliferation phase now of tissue repair, which does overlap with the inflammatory stage. What it involves is cells replacing damaged tissue, proliferating and migrating into the wound to allow either regeneration or scar tissue formation. So here you can see we've got a wound here that has extended down through the epidermis and into the dermis, and you can see we've got the first phase there of tissue repair being coagulation and that blood clot forming. Now, scar tissue formation starts with a particular type of connective tissue called granulation tissue forming, and this is a very red and moist tissue. It's called granulation tissue because it does appear kind of granular and lumpy, and it's due to the presence of these proliferating fibroblasts that are making collagen. We've also got capillary growth into the affected area due to the process of angiogenesis, and that's done to bring sort of more blood flow to the area with oxygen in it and chemical mediators. So this gives this first sort of connective tissue that's formed this red and moist appearance. And it does, involve fibroblast proliferation, capillary growth, and ongoing sort of macrophage activity to clean up the area, and mast cell activity. And mast cells are tissue cells that, secrete histamine. And then we move into the remodeling phase, which is this conversion of this initial granulation tissue, which you can see here, to scar tissue. So what is happening in this phase is the collagen synthesis increases, fibroblast proliferation starts to slow down. We're going to get sort of vascular degeneration occurring. So those, capillaries that formed in the granulation tissue are going to degenerate. And eventually then we end up with this scar tissue. And remember that the function of, scar tissue is to allow for partial function, but also to prevent sort of, neighboring cells and tissues from getting damaged. And its composition contains dense extracellular material. So that just means, mainly consists of packed collagen fibers. Also contains some kind of spread out fibroblasts. It's pale in color and it's largely avascular. So avascular meaning largely doesn't have any sort of blood supply flowing through it. And it then often contracts to shrink and become less visible over time. So as it contracts, it kind of pulls on the wound, the edges of the wound, pulling it together, which is a good thing. But sometimes this happens too well, and that can then result in, further restriction of movement and also pain.